The TOPS clinical trial is a national study being performed at roughly 32 institutions across the country, in which we're looking to see if there's an alternative to spine fusion for a condition known as degenerative spondylolisthesis in the lumbar spine. Degenerative spondylolisthesis is an arthritic condition in which the bones in the back slip one over top of another, the result of which is compression on the spinal cord or spinal nerves, causing not just back pain, but leg pain, leg weakness, numbness, tingling, sometimes difficulty walking distances. Currently, the gold standard treatment is a spine fusion, which traditionally has done very well. What we do with a spine fusion currently is use the old screws and rods, where we put pedicle screws into the bones and then we connect them with rods that will keep the bones still until your body fuses the two segments together. The problem with fusion is that it creates stress at the levels above and below the level that we fused. The TOPS procedure is an alternative to treat that same exact condition, but rather than fuse, we put an implantable device that allows motion. It's constraining in the sense that it's not going to allow the slippage to continue, but it will allow motion at that segment, which hopefully will preserve the levels above and below from getting arthritic in the future. Currently, the study is done across the country. Here in the US, it's FDA approved. The enrollment is for a blinded study, which means patients who enter the study won't know if they're going to get the TOPS or the fusion, but 2/3 of the study will get the TOPS device, which again is the mobile implant. 1/3 will get fusion, which again is the gold standard, and patients do very well with a one-level fusion. And then we're going to follow these patients over the course of at least 5 years, looking at different x-rays and questionnaires, seeing how patients are doing, and compare the two groups together. The hypothesis of the study is that the TOPS will do equally as well, if not better, in alleviating symptoms in the short term, as well as hopefully preventing adjacent level problems in the future. Currently, the study has very specific indications and contraindications. The surgical indications are it has to be a one-level arthritic degenerative spondylolisthesis, which is that forward slippage of one bone on top of the other. There are age limits. It's 35 to 80 years old. It cannot be at L5-S1, which is the second most common level to get an arthritic condition in the back, L4-5 being the most common. So if patients have a problem at the L5-S1 level, currently this device will not be indicated for them. Patients also need to fail 6 months at least of conservative measures for any surgery that I really do for them, but in particular this one that's important. Those include physical therapy, epidural steroid injections, activity modifications, medication. There are some comorbidity exclusions, diabetics that are uncontrolled, morbid obesity with BMI over 40, systemic inflammatory disease like rheumatoid arthritis. Surgical contraindications also include previous surgery, previous fusion surgery, revision surgery, scoliosis or other structural abnormalities to the spine. Anyone who currently is involved with any sort of infection or tumor is not a candidate for the surgery. They have to have a good disc, and we use that term good disc kind of relatively because it depends on what their disc looks like on x-ray and on MRI. It cannot be bone-on-bone arthritis in the disc space because again we're trying to preserve motion, so we need a relatively healthy disc. The risk of the operation are the same as any other operation we would do. Of course, there's always a small risk of bleeding, infection, and blood clots with any surgery in any field. Pertinent to spine surgery, there's a small risk of injury to nerves. Most patients ask, can I be paralyzed? You cannot be paralyzed from this surgery. At the levels in the lumbar spine we're working on, there's no risk of paralysis. Worst case scenario would be some weakness or numbness in a foot or an ankle. And again, that's very infrequent, and that's with any spine surgery we do, not just the TOPS procedure. This device will be motion preserving. I've not seen anything this revolutionary in the 10 years I've been in practice, and I'm extremely excited about where this device is going to take us into the future.